On today's episode of 340 Banter, we are joined by Felicity, and we're on site at the Midwest 340B conference.
I'm just happy to be here. I will say that when Chelsea was a resident, often she played the role of Felicity. She's done that throughout her career. And so it feels fitting that I am sitting in the co-host seat today and for a few of these episodes.
So it's been a busy few weeks in the 340B space, and recently HRSA released their rebate model pilot. At the time of filming, it's still in the comment period, so we thought it'd be a good time to talk about what we've seen. By the time you get this in recording, it may be a little bit different, but let's go with the information we've seen so far.
Yeah, it's been a wild summer, to say the least. We've all been trying to relax, get a little sun, and the Office of Pharmacy Affairs has definitely been interrupting our relaxation. That I can say for sure. Every time I go to give a presentation, they're dropping something new, and not the heat that's making us sweat, but the rebate models. So we've seen a couple different things. One, they dropped the new 340B pilot program that is being proposed, and we have open for comment. So initially the comment was going to close on August 1st, but they did publish
September 1st.
Oh, yes. Ooh, that's right, September 1st. But they did publish a correction, and now it goes till September 8th. And then also they dropped a new frequently asked question on the Office of Pharmacy Affairs website. They have a page now dedicated to the rebate pilot.
So as we've been digging through the rebate pilot rules and actually developing comments ourselves, what are some of the biggest highlights that we've seen in the rebate model?
Yeah, so number one, most importantly, it is only applying to the first 10 drugs that are selected for the Medicare drug price negotiation program. So there are 10 drugs for the first year, 2026, and only their manufacturers are able to apply. So it's a limited group. What we did see in the FAQs that they just published is that while the Medicare Part D program is only in the retail setting, that the Office of Pharmacy Affairs is interpreting this new pilot program to be both in the retail setting and for physician and clinic administered drugs. So that was something that we weren't anticipating, that they did clarify in the FAQs. So that's one big thing to note.
And that's really challenging because some of the aspects that they're looking for in the rebate model are BIN and PCN, and we don't have those for clinic administered drugs. So I really am not sure how we'll meet those requirements.
Yeah, so you make a great point. There is defined in the pilot program that's being proposed 11 elements that the manufacturers can request that HRSA has essentially put forward as potential elements. And they include things that we've seen previously. So the date the prescription was filled, information about the pharmacy, information about the covered entity, refill number. But what was unique to this list was the BIN and PCN, or the bank processing information. When we say BIN and PCN, those are really specific to the claim and the insurance information. And so from there, what we called out in our comments that we're submitting is that only 38 of the 39 manufacturers who are currently restricting for 340B for contract pharmacies have asked for this information, and also that CMS in their proposals for the inflationary penalties, when they're talking about the data repository that is coming in fall of 2026, which will be voluntary for removing 340B claims from the inflationary penalties for Medicare Part D as well, are not asking for the BIN and PCN information. So it makes it different from what we're seeing from everybody else. And so we're encouraging the Office of Pharmacy Affairs perhaps to reconsider it. It doesn't fit with the physician-administered drugs and the clinic-administered drugs, and it's also just not standard for what we're seeing in the industry.
It would also create problems in entity-owned pharmacy relationships when you're not using a BIN and PCN. So a lot of those cash card or cash discounts that you're providing, where you're giving the 340B discount to the patient, they're an internal plan. They're not processed through a payer. So they're not going to have that bin and PCN. So it's going to be very challenging. In talking about the cash discount, I think that that's a really concerning thing, especially for FQHCs that do have to give discounts on medication, that they're not going to be able to provide that. And so let's chat about that a little bit.
Yeah, so to walk it back just a little bit, right, the way that the rebate model has been proposed is that the manufacturers will be selling the drugs at an upfront wholesale acquisition cost to the covered entities for the ones that are selected. We don't know if it's going to be all 10 that are going to be in the rebate model or just a small portion. So we'll buy those at the full price, and then we'll be dispensing those to the patients and getting rebated back down to the 340B price. The question is, right, we're not going to see the 340B price when we purchase these medications. On our wholesaler account, we're going to have the wholesale acquisition cost, or what we refer to as WAC cost, loaded into our accounts. And so it's going to be a lot more challenging for us to pass on that 340B price, both to our patients who are receiving our sliding fee scales or our discount programs, but then also questions have come up around Medicaid too, when we have to offer that price to Medicaid. So it's creating a really challenging situation. The Office of Pharmacy Affairs has put out an FAQ, particularly around the Medicaid portions, suggesting that you work closely with your Medicaid state agency to figure out what the best way is to address it. They've also reminded us that on the Office of Pharmacy Affairs information system, or OPACE, that there is the pricing tool that's available to be able to find those 340B prices. That is limited to the authorizing official and primary contact. So it does make it a little bit more challenging for us to be able to provide those discounts up front, especially when we're just starting out and we're not certain how these rebates are going to flow and if we are going to actually receive them.
Just in case people don't know, the way these systems work, like our pharmacy software, we get a price file from the wholesaler, and that's the price that is used in calculation of a cash discount or sent to Medicaid. And going forward, our wholesaler price file is going to be WAC. So it's going to be challenging to get that price loaded. And with OPACE, those two people can get access to the ceiling price, but it's one NDC by one NDC. It's not exportable currently. So it'll be interesting to see what HRSA does and what they allow the PVP to do, if there's different ways that we can get that pricing going forward outside of the OPACE pricing tool. Because also with our PVP pricing, if you're used to logging into the portal and downloading the catalog, that's based off of wholesaler data currently. So it's also going to show WAC price.
Yeah, we're seeing too in our conversations with the wholesalers that they're concerned as well, just because of the increase in pricing that we're going to have for covered entities. You know, how are they going to be able to manage the new upfront costs? You know, our increase in credit limits. Are people going to be able to get approved for credit limits? There's a lot of challenges that we are seeing just being anticipated, and there's a lot of work that's happening in the industry from those who support covered entities to try to prepare for this. But it's important too for the covered entities to be aware, to review that pilot proposal, to be making comments of your own, and just to start thinking about what is this going to look like, because we're going to have the two disruptions happening at the same time. The rebate models are set to start in the beginning of January, but then we're also going to have the Medicare transaction facilitator and the maximum fair prices coming in at the same time. So it's going to be two real industry disruptions happening at once that we need to be ready for.
So I know there's been some confusion about the model being voluntary. And a lot of covered entities are asking, is it voluntary for us? And I don't think they're going to like the answer.
Yeah. So the headline of it is that it is voluntary, and it's voluntary for the manufacturers of those 10 negotiated drugs. They get to choose whether or not they will put in their proposal, again, for that September 15th deadline. And what will happen is by October 15th, the Office of Pharmacy Affairs will let us know who's selected. The manufacturers do have a lot of leeway, both to choose to participate, but then in the FAQs that were published by OPA, they also let us know that the manufacturers can choose who are they going to include as far as covered entity types in their models. So it's not necessarily that the manufacturers will include everybody in the model. They may actually choose to do either all covered entities or a selection of covered entities, and then just looking back at the manufacturers who had come out and proposed rebate models in 2024, we had 5 of them. 4 of them have drugs that are on the list. And of those 4, it's actually a 50-50 split. So half of them only suggested that they would do restrictions for the disproportionate share hospitals. And then the other half said that they would do it for all covered entity types. We don't know if that's going to actually continue for what we see come in January. We'll have to wait until we see the published summaries from the Office of Pharmacy Affairs from the proposals. But what we do know is what they did before. So it gives us a little bit of an indicator. We may see a mixed bag.
Well, and the interesting thing with Sanofi's model, and they don't get to participate because they don't have a drug in 2026 or 2027, right?
Yes, and based on my review, and this is a lot of extrapolation because we're quite a bit behind in the published data from CMS around Medicare Part D and Part B purchasing, is probably 2029 before we see them on the list.
Yeah, and they were kind of unique because you said we had the 50-50 split. They were kind of unique that they included health centers in with certain hospital types and are treating us as hospitals like they're doing with their contract pharmacy restrictions.
Yeah. The other thing that made Sanofi unique was that they were also looking at doing a patient eligibility determination. And so they asked for information about diagnosis, and we have not seen that from any of the other manufacturers at this point, nor are we hearing allusions in the industry that that will be happening. And
so that's a great point. Let's talk about, can manufacturers make that determination in the rebate model? Are they allowed to look at patient definition?
Yeah. So the way that the proposal has been written, right, for the pilot program, is that manufacturers are not able to deny the rebates for diversion or duplicate discount as the only reason that they're denying them. There are a couple examples that are given in the pilot proposal, and then manufacturers may also make additional justifications when they put their plans into OPA. And so the 2 reasons that were given in the pilot program proposal were if 2 covered entities sought a 340B rebate on the same claim, or if there was a maximum fair price duplication with a 340B rebate. This is a place where we are seeking clarification from the Office of Pharmacy Affairs, because really we only want that duplication to be allowed when the maximum fair price is lower than the 340B price. So that would be the best price in the market. Otherwise, if the maximum fair price is higher, we really should be being rebated down by the manufacturer to our 340B price.
Yep. Because we are supposed to get the best price out of those 2.
That is the way the law is written.
Yes. And I think to kind of wrap things up, let's talk about what covered entities should be doing to prepare when they're talking about dealing with the rebate model platforms and the conversations we've had with those vendors.
Yeah. So besides deep breathing, because we are encouraging a lot of deep breathing and stress relief, perhaps a massage, we've talked to the vendor platforms, and it's important to know that signing up for these is going to be more time consuming. Because there is going to be money moving between different parties, there is the requirement for setting up the bank accounts as well. And so what they refer to as penny testing, where they do a test transaction. And so enrollment into the rebate platforms is going to take a little bit longer than it did to sign up for previous manufacturer management platforms. And so just encouraging people to think about getting this done earlier, right? We've encouraged people to sign up for the Medicare transaction facilitator early. This may be something that you want to do as well. We see the ball is moving down the hill, right? It is coming as much as we wish it wasn't. But just getting prepared for having this set up, because if we're all waiting till the last minute, this could cause significant disruptions in how funds will flow. But I think one piece to talk about is that OPA did do one thing that was positive in this, in setting the 10-day expectation that once the claims are submitted, the covered entities have 45 days to submit their claims to the platform that's selected by the manufacturer. Once those are submitted, the manufacturers have 10 days to either pay the claim or give a justification for why the claim was not paid.
So even though this is a fundamental shift in the program, I think HRSA was very thoughtful in their remarks, and hopefully with the comments given, this program will be better for all stakeholders in the program. But we're going to be watching it closely, and we'll follow up as we get more information from HRSA.